Okay, so good afternoon, everybody, for those of us on the East Coast, and hello to those joining us from other sites. Welcome to our final ASBMR Early Stage Investigator clinical workshop series for the year. Today, we will be talking about rare metabolic bone disease, in particular fibrous dysplasia. First, I'd just like to start off with some housekeeping. I'd like to inform all attendees that this session is being recorded and kindly remind you to keep yourself muted for the duration of the presentation. At the end of the talk, we will have a 15-minute Q&A session, which will be moderated by Dr. Elena Sordi from Dresden University in Germany and Dr. Elizabeth Winter from Leiden University in the Netherlands. I would like to remind you or encourage you rather, to submit any questions you might have throughout the duration of the talk using the Q&A session. So please don't put questions in the chat function, use the Q&A function to submit your questions. And without further ado, I'd like to introduce our two speakers for today. We have Dr. Allison Boyce, who is a pediatric endocrinologist and chief of the Metabolic Bone Disorders Unit in the National Institute of Dental and Craniofacial Research at the NIH. The goal of Dr. Boyce's work is to enhance health and well-being for children with skeletal disorders by developing novel tools and treatments informed by pathophysiological studies. She leads investigations in fibrous dysplasia, McCune-Albright syndrome in particular, and has characterized many aspects of this disorder and its treatment. Dr. Boyce is a faculty member in the NIH Endocrinology Fellowship Training Program and is a member of the Fibrous Dysplasia McCune-Albright Syndrome International Consortium and serves as chair of the Medical Advisory Committee to the FD-MAS Alliance. Dr. Vivian Szymczuk is a clinical fellow in pediatric endocrinology at the NIH. Dr. Szymczuk is specializing in disorders of bone and mineral metabolism and has joined Dr. Boyce's lab at the Metabolic Bone Disorders Unit and plans to continue clinical and translational research in combination with patient care upon completion of a fellowship. I would like to welcome and thank Dr. Boyce and Dr. Szymczuk for joining us today and hand over to them now for their presentation.
Great. Thanks very much for that introduction. Can I confirm if you're able to see my slides?
Yes, Dr. Boyce, thank you.
Great. Thank you very much for the introduction and for the opportunity to speak on this topic, which is near to both my heart and Vivian's heart. So we will be presenting several cases and discussions that will shed light on diagnosis and management in fibrous dysplasia. These are our disclosures. So fibrous dysplasia McCune-Albright syndrome is a complex mosaic disorder of G-alpha S activation. So it can involve any part or combination of the skeleton and many parts and combinations of the endocrine system. So this complexity makes FD-MAS a really fascinating disorder to understand the role of G-alpha S and the interplay between the different systems that are affected by its activation. But it also makes this a very challenging disorder for clinicians who have the job of trying to diagnose and manage a disorder where no two patients look alike. So FD-MAS arises due to mosaic activating mutations in the alpha subunit of the GSG-coupled protein receptor. So this is a key receptor responsible for signaling in multiple tissue types, but particularly the bone and endocrine systems. In the mutant receptor, the GTPase activity of the alpha subunit is lost. And this leads to constitutive receptor activation and inappropriate production of intracellular cyclic AMP and other downstream signaling proteins. So it's the constitutive receptor signaling through the different tissue types that leads to the clinical features of the disease. So constitutive signaling through the melanocyte stimulating hormone receptor leads to skin hyperpigmentation. Constitutive signaling through LH and FSH receptors leads to precocious puberty. Patients have overproduction of thyroid hormone, growth hormone, etc. And a key aspect of FD-MAS that's important to understand in in approaching its management is the fact that this is a mosaic disorder. And its mosaicism is inherent in the clinical features. So the skin hyperpigmentation occurs in this classic distribution along the midline of the body and typically has these irregular jagged borders. And this follows patterns of early embryonic cell migration, sometimes called developmental lines of Blaschko. The bone disease is very patchy and mosaic and can range anywhere from trivial disease affecting only one or a few bones to severe disease affecting nearly the entire skeleton. And the endocrine gland involvement as well can be quite patchy and variable, as you can see here in this patient who has unilateral testicular involvement. Another key aspect of mosaic disorders is the fact that this is not a disease that's passed from parent to child. There have never been a documented case of vertical transmission. This probably reflects the fact that germline mutations in G-alpha S are likely lethal, so these mutations likely can only survive through mosaicism. And this picture here shows our current understanding of pathogenesis in FD-MAS. So a mutation occurs by chance very early in embryogenesis, and then the progeny of that mutated cell spread throughout the developing fetus, forming tissue that will then be affected by disease. So if we have a patient with a phenotype that has disease involving tissues derived from all three germ layers, i.e. the ectoderm, mesoderm, and endoderm, which comprise the bone, skin, and endocrine systems, we know that by necessity, the inciting mutation had to take place very early before the germ layers derive. In bone, mutations in G-alpha S impair differentiation of skeletal stem cells. So these are multipotent stem cells that normally differentiate along a number of lines into osteoblasts, chondrocytes, adipocytes, and hematopoietic supporting cells. In the mutant state, this differentiation process is disrupted, and the cells instead form abnormal osteoblasts. And it's proliferation of these abnormal osteoblasts that lead to the histologic composition of the lesions. So we see that in FD, we've lost all of the normal marrow architecture. Here you can see in the normal state, we have nice lamellar bone, we have normal marrow tissue. And in FD, all of that is disrupted. Instead, we just have sheets of this fibrotic tissue, which represents proliferating skeletal progenitor cells. We can also see formation of large areas of abnormal woven bone, which is very poorly mineralized, as evidenced here by this visible osteoid. And the clinical features of fibrous dysplasia vary a lot depending on how much of the skeleton is involved and what specific areas of the skeleton are involved. So from a clinical standpoint, it's useful to divide the skeleton into three major components. The craniofacial skeleton, comprising the skull and jaws, the axial skeleton, comprising the spine and ribs, and the appendicular skeleton, comprising the long bones. So in the skull, most problems from fibrous dysplasia arise due to its tendency to expand. So this can lead to facial asymmetry, and in rare instances, this expansion can invade into areas responsible for function, leading to issues like vision and hearing loss. In the axial skeleton, we often see problems due to the deformity of the bone under weight-bearing forces. So it's common to see scoliosis in the spine. The ribs can also be very fragile and are prone to fractures and can expand and create deformities. And in the limbs, again, there's a lot of issues due to deforming under weight-bearing forces. Patients develop bowing deformities of the lower extremities, and also fractures are a big problem in fibrous dysplasia. So with that introduction, I'm going to hand it over to Vivian, who is going to present on our first case.
All right, so we have our first case. This is a 2-year-old girl who was diagnosed with McEwen-Albright syndrome after presenting with vaginal bleeding and macules. She had a technetium-99 bone scan, which showed no FD, and labs showed no endocrinopathies. As you see over in the right, this is her technetium-99 bone scan. We see bilateral symmetric uptake at the level of the growth plates, but no concerning uptake in other areas concerning for FD. She was treated with letrozole until age 10 with good response. By age 13, she achieved normal adult height, having regular menses. There were no clinical signs of other endocrinopathies, and so therefore she was discharged from the endocrine care with further follow-up by her pediatrician. At age of 13, however, she developed progressive aching pain in her bilateral hips, categorized as 3 to 5 out of 10 in severity, worse at night and with activity. She had radiographs, and she had a radiograph that was performed, as you can see on the left-hand side, which showed ground glass appearance. You can see at the right, the red lines, the arrows there, along with scalping. She also had a technetium-99 bone scan, which was performed, showing tracer uptake in the skull and the upper and lower extremities. So she was subsequently diagnosed with polyostotic FD. So the questions become, why wasn't this picked up at her initial evaluation? And what additional workup would be needed for her?
Great. Thanks, Vivian. And I think this is an excellent case that shows the age-related phenotype in fibrous dysplasia. So I shared on a few slides earlier that fibrous dysplasia results from a mutation acquired during embryogenesis. So patients at the time of birth, we know that the map of affected tissues has already been charted. However, it takes time for those mutation-bearing skeletal stem cells to proliferate enough to form a discrete lesion. So the typical presentation is that bone formation appears to occur pretty normally in utero, and we don't usually see obvious signs of fibrous dysplasia at birth. But you can see here in this graph that was derived from our natural history data from our study at NIH, that the amount of fibrous dysplasia that patients has increases dramatically over the first few years of life before gradually tapering off and reaching final disease burden in adulthood. So we see that by age 5, 50% of the total amount of FD that's going to ever be there will be present, and that final disease burden is established in late adolescence. Interestingly, we also see an age-related phenotype in adults. Serum bone turnover markers decline over time in patients with fibrous dysplasia. And if we look at lesion histology in older adults or patients greater than 35 years, we actually start to see less of those mutation-bearing skeletal progenitor cells and even start to see some reconstitution of almost normal marrow features. This probably reflects the fact that the mutation-bearing skeletal stem cells have a limited lifespan, and over time their presence declines either due to apoptosis or senescence. So I'm just going to go through our recommended clinical approach for initial screening in fibrous dysplasia. So in any patient that has either known or suspected fibrous dysplasia, we always start with a targeted history and physical exam, looking for clinical signs of bone disease. And from there, our approach derives depending on the patient's age. So in patients who are less than 5 years old, if we don't see any clinical signs of bone disease, so no fractures, no limp, no obvious deformities or bone pain, those are patients that we can monitor clinically. If we do see signs of bone disease, then patients should have skeletal imaging, radiographs. They should be referred for vision and hearing evaluation and have a serum phosphorus level checked. Once patients are age 5 years or older, we start our approach with a nuclear medicine bone scan to look for areas of fibrous dysplasia. So this is usually a technetium-99 bone scan, but patients could also have a sodium fluoride PET CT. Any areas of abnormal tracer uptake are typically consistent with fibrous dysplasia lesions. So they should then be imaged with more targeted techniques, such as radiographs. Should get a head CT if there's any tracer uptake in the skull, and check a serum phosphorus. If we have a normal nuclear medicine bone scan in a patient aged 5 years or older, that is a patient that is unlikely to ever develop any clinically significant FD. We don't recommend any further imaging, and patients can just be monitored clinically. So that's FD, but what about endocrinopathies? How do we screen for those? And this is a really important aspect of the disease because we know that endocrinopathies are something that can increase skeletal morbidity in patients with FD. And here's data that I'm going to show from our natural history study at NIH. We have seen that hyperthyroidism and hypophosphatemia both increase risk of developing more fractures and earlier fractures. They both increase the risk of developing progressive scoliosis. They increase risk of developing skull-based deformities, in particular basilar invagination, which occurs when the cervical vertebrae is displaced through the skull base and can lead to neurologic complications. And we see that growth hormone excess increases the expansion of craniofacial FD, leading to more facial asymmetry and higher risk of vision and hearing loss. And I always think it's particularly important to emphasize this relationship between growth hormone excess and craniofacial morbidity, because this is one area where we have good data that if we can screen for growth hormone excess and start treatment early, we can actually prevent a lot of these problems. And I think this is represented by these two individuals that are featured on the screen here. So both of these patients, the patient at the top and the patient at the bottom, have equal severity of growth hormone excess, and they have an equal extent of craniofacial FD involvement. But the patient at the top was diagnosed with growth hormone excess at age 9 and started on treatment right away. And you can see that overall, she has generally symmetric facies. And importantly, she has patent optic canals with normal vision and normal hearing. The patient on the bottom was not diagnosed or started on treatment until age 18. And we can see that in contrast, he's developed really extensive overgrowth of his skull, particularly here in the mandible and in this maxilla. And unfortunately, he has occlusion of both optic canals, which has led to vision loss. So again, we recommend kind of systematic approach to for screening and monitoring patients for endocrinopathies. So with all patients with either known or suspected MAS, of course, we start with a targeted history and physical exam. For pediatric patients, it's important to review the growth curve. And then we recommend obtaining, in all patients, screening thyroid function tests and an IGF-1 to screen for growth hormone excess. We also recommend for all patients at screening a bone age if they're pediatric, and also thyroid and testicular ultrasounds to look for subclinical disease. If all of these tests are normal, ongoing monitoring is really targeted. For pediatric patients, again, we continue to monitor their growth velocity. If patients have craniofacial FD, we do recommend continuing to periodically check IGF-1 levels. Because growth hormone excess is one of those endocrinopathies that can actually develop later. The latest I've diagnosed this is actually in a patient 26 years old. So it can creep up over time. In children who are under age 10 years and have an abnormal thyroid ultrasound, we do recommend continuing to monitor thyroid function tests, because this is a case where hyperthyroidism can actually develop over time, even if they have normal thyroid function tests at screening. And we don't recommend any further routine imaging. So the main takeaway points from case 1 are that FD lesions are established in a predictable age-related pattern, and that a complete staging evaluation at age 5 or later can identify areas of clinically significant FD, and that ongoing targeted monitoring for endocrinopathies is recommended. So again, I am going to turn this over to Vivian, who will share a separate but related case.
So here is case number 2. This is a 20-year-old woman with bone pain. She was diagnosed with fibrous dysplasia at the age of 13 after presenting with right-sided hip pain. As you see on the right, she had a technetium 99 bone scan, which was performed and showed tracer uptake in her lower extremities, more so on the right than on the left. Her radiographs showed again that heterogeneous ground glass appearance that you see on both the right and the left, obviously more extensive on the right. She was seen by an orthopedist who started zoledronate for pain relief. She received infusions every 3 to 7 months for the next 3 years with 5 total infusions and reported moderate pain relief. Lab work was performed, which showed a low phosphorus at 2.2 with a normal range of 2.5 to 4.5, and an alkaline phosphatase, which was elevated at 142 with a normal range of 37 to 116. Further lab work showed an FGF23 level, which was elevated at 210 with a normal range of less than 180, and a tubular reabsorption rate of phosphorus of 83, which is low, with a normal range of 85 to 95. So the diagnosis for the low phosphorus was FGF23 hypophosphatemia. So the question becomes, what treatment would you start for this patient? And should she continue zoledronate?
Thank you. So for the trainees, I thought I'd just give a very brief background on fibroblast growth factor 23, because this is one of our favorite hormones, but it's also quite complex. So this is the hormone that primarily regulates phosphate metabolism in the body. FGF23 is made by bone cells, and it then acts on the kidney to decrease expression of NaPi2A and decrease expression of 1-alpha hydroxylase. So the net effect of these actions are to increase the excretion of phosphate into the blood and decrease the levels of phosphate in the blood. Also, it impairs the production of the active 125 dihydroxyvitamin D. So patients will have inappropriately low levels of that in the blood. So early on in our work in fibrous dysplasia, we made the observation that the patients who had hypophosphatemia tended to be the patients that had more severe FD. And the reason for this is that there's a linear relationship between the amount of fibrous dysplasia someone has and the amount of FGF23 that's present in their blood. And this is because FD actually produces this excess FGF23. And it was the recognition that in FD, the pathologic bone is the source of FGF23 production that inspired studies in normal bone, and where we were able to confirm that bone is indeed the physiologic source of FGF23 in normal physiology. So I think it's a nice example of how studies in rare disease can inform and improve our understanding of normal physiology. Also, FGF23 mediated hypophosphatemia is something that can wax and wane over time. Patients can have fluctuations in their phosphorus levels, and this likely reflects differences in growth and phosphate needs, as well as differences over time in how active the FD lesions are. So I shared these images earlier, but I just wanted to show them again because they're quite relevant. So again, we care a lot about hypophosphatemia in FD because it can increase fibrous dysplasia related complications. So it increases risk of fractures, increases bone pain, as well as risk of deformities in the skull base and in the spine. So management of hypophosphatemia in FD is similar to management in other FGF23 excess conditions. So the most common approach is to use conventional therapy. So I shared on the slide that in FGF23 excess, we have two main metabolic defects. We have low serum phosphorus levels and we have low 125D levels. So conventional therapy involves orally replacing both of those. So we give oral phosphate, which is administered 3 to 5 times a day. Unfortunately, it's often limited by GI side effects, GI intolerance. And it can also cause secondary hyperparathyroidism with increasing PTH levels. We also give active vitamin D in the form of either calcitriol or alpha-calcidiol, which can prevent secondary hyperparathyroidism. But unfortunately, these medications treatment is often dose limited because they can cause increased urinary calcium. So there's Burosumab, or anti-FGF23 monoclonal antibody, represents a newer and more targeted approach for treating FGF23 excess. And this is a treatment that's been approved by both the FDA and the EMA for treatment of X-linked hypophosphatemia and tumor-induced osteomalacia, which are other FGF23 excess disorders. So Burosumab has been shown to very robustly correct hypophosphatemia. to improve muscle function and to heal insufficiency fractures. So it's a really excellent treatment. And it's also encouragingly been shown to be very safe and is not associated with the hypercalciuria or the GI effects that we see with conventional therapy. Burosumab is extremely expensive. It costs about $200,000 a year and has not yet been studied or approved for use in FD. So this begs the question, is there a role for Burosumab in treating patients with FD? So in consideration on the pro side, we know that Burosumab in comparison to conventional therapy is better tolerated. We see less GI and renal side effects. Also, it's much more easily administered, so patients tend to have better compliance. Some theoretical considerations. When I shared earlier the histology images of fibrous dysplasia, I pointed out that there's very prominent visible osteoid. So FD tissue is by its nature poorly mineralized. And it's unknown whether a medication like Burosumab might improve that tissue mineralization. It's also unknown whether patients with FD might benefit from maintaining a higher serum phosphorus level. With conventional therapy, the best you can do is to squeak that phosphorus into the lower end of the normal range, because if being any more aggressive with treatment, you run into renal and GI effects. But with Burosumab, you have the ability to target a mid or even upper end of the normal range for serum phosphorus. But on the con side, I think the major one is expense. Burosumab is extremely expensive and conventional therapy is extremely affordable. Also, the target population for Burosumab is less clear in FD. The hypophosphatemia overall tends to be more mild than XLH or TIO, and many patients can be relatively easily managed with conventional therapy. We don't have any safety data for Burosumab use in FD. And we also, again, need to consider possible deleterious tissue effects. FD is a neoplastic process. We don't know how Burosumab might affect proliferation of the abnormal skeletal stem cells, and we don't know how Burosumab might affect FD lesion growth or activity. So taking all of this together, I think where we stand for right now is that Burosumab is likely a reasonable option for patients who have significant FD and are experiencing ongoing skeletal complications that can't be managed effectively with conventional therapy. The FD tissue effects are important unknown questions which do need to be studied, and we are currently in the process of developing a clinical trial for Burosumab at the NIH. So hopefully we will have some light on these issues soon. I'm going to shift gears a bit and talk about other causes of pain in FD. This is a complex disorder. While hypophosphatemia can certainly be one factor that contributes to pain, there are many others we need to consider. So in FD, skeletal deformities can often lead to pain due to the stress put on the joints, due to the differences in the way the weight-bearing forces are distributed throughout the body. Patients frequently have leg length discrepancies, which can contribute to pain. Craniofacial expansion, as I've talked a bit about, can rarely lead to compression of nervous structures and structural complications like basilar invagination that can present with pain. And FD is inherently a high bone turnover disorder. It's unknown but suspected that the formation of all this abnormal bone and osteoclastogenesis may contribute to pain. And as I've mentioned, FGF23 excess and hypophosphatemia can contribute to pain. So putting all of this together, pain is quite common in FD. Our retrospective studies show that it affects about 80% of adults and about 50% of children. So this algorithm here shows our current clinical approach to management when patients present with pain. So pain that is focal, that's limited to one spot, and or acute, so been present for 6 weeks or less, it's really important to be suspicious of structural or orthopedic causes. So those patients need to be evaluated for a current or an impending fracture, for the development of a secondary bone cyst within an FD lesion, which can present with pain, or other orthopedic issues. So if pain is diffuse, so it's involving more than one FD lesion, and or it's been chronic, present for greater than 6 weeks or more, those patients should always be suspected for for the possible development of hypophosphatemia. So as I shared on a previous slide, hypophosphatemia can wax and wane, come and go. So even if a patient has a previous normal phosphorus level, it's a good idea to check it again. Once that's been addressed, patients can be managed with NSAIDs and supportive care. However, if we have patients who present with persistent, moderate to severe pain and normal phosphorus levels, that's when we consider using bisphosphonates. So pamidronate or zoledronate, which we dose according to symptoms. So on here, I'd like to go a little more into the use of bisphosphonates and other anti-resorptives in FD, because this is a common question that we get clinically. So the reason that anti-resorptives were even targeted in FD grew out of the observation that lesions are in a state of high bone remodeling. So we see this clinically because in children, FD lesions are expanding and growing, and that requires them to invade into adjacent areas of normal bone. We see this biochemically because patients have increased serum markers of both bone formation and bone resorption in the blood, and that these levels correlate with the amount of FD that they have. We also see this histologically because FD is characterized by massive areas of abnormal bone formation, as well as prominent osteoclastogenesis. So that led us to ask the question, could targeting these osteoclasts with anti-resorptive medications like bisphosphonates be an effective treatment strategy for FD? So we performed a placebo-controlled trial of alendronate, which is an oral bisphosphonate in patients with FD. And this was a trial involving 36 patients over 2 years of treatment. And what we saw is that alendronate treatment was associated with reduced markers of bone resorption in the blood, although we did not see any effect on bone formation markers. We saw an increase in FD lesion density in children only, but we did not see any effect on FD lesion density in adults or in the overall group of patients treated with alendronate. And unfortunately, we did not see any change in pain with treatment or changes in other clinically relevant endpoints, such as fractures, measures of physical performance, or in the radiographic appearance of FD lesions. Based on the data that we saw in the DEXA scans, we performed retrospective studies looking at the ability of bisphosphonates to prevent FD lesion formation or expansion in children. And unfortunately, we did not find that even high-dose bisphosphonate treatment was associated with any decrease in FD lesion progression in kids. And additionally, a really excellent study came out of the group at Shriners in Montreal, where they had bone biopsies in children before and after bisphosphonate treatment and did not see any change in FD lesion histology or histomorphometry. And concerningly, we began noticing the development of osteonecrosis of the jaw in some of our patients with FD. So out of 76 patients in our NIH cohort who have received bisphosphonate treatment, 5% of them actually developed ONJ, which is similar to the prevalence we see in patients treated with bisphosphonates for bone cancers. So right now, current evidence really only supports the use of bisphosphonates for pain relief in FD. Unfortunately, there is no evidence to support beneficial effects on bone quality or other skeletal outcomes. And we recommend using the lowest dose and interval needed to achieve symptom relief. And more specific recommendations for our use of bisphosphonates are available here. These are international consensus guidelines that were developed for FD-MAS as part of the FD International Consortium. So we recommend using intravenous formulations, pamidronate or zoledronate. And instead of putting patients on a set dosing schedule, we recommend using the minimum dose and interval that we need to improve bone pain, because that will allow us to keep the overall exposure to bisphosphonates as low as possible. And then we also recommend monitoring oral health closely, as well as monitoring the density of non-FD bones who will also be exposed to the anti-resorptive effect of bisphosphonates. So we know that unfortunately targeting osteoclasts through bisphosphonates does not seem to be effective in improving FD lesion quality. But we do have other mechanisms for targeting osteoclasts, specifically receptor activator of nuclear kappa B ligand, or RANKL. So this protein is a member of this tumor necrosis superfamily. It's produced by osteoblasts and osteoprogenitor cells, and it binds its receptor RANK on osteoclast precursors, which promotes formation of active osteoclasts and bone resorption. And the reason we're so interested in RANKL is this is a protein that's targetable with medication, denosumab. This is a monoclonal antibody to RANKL that's been approved by the FDA since 2010 to treat osteoporosis, bone metastases, and giant cell tumors of bone, which, similar to FD, are actually neoplasms made of skeletal progenitor cells. So we have growing evidence that RANKL seems to play a key pathogenic role in fibrous dysplasia. So we see increased serum RANKL levels in the blood of patients with FD, and these levels correlate with overall skeletal disease burden. We see high levels of RANKL expression in FD tissue, and this expression correlates with areas that are more active with increased cell proliferation and Ki67 staining. We also see that FD cells secrete RANKL in vitro, and when co-cultured with pre-osteoclastic monocytes, are able to support the formation of mature osteoclasts. So based on this line of thinking, we have been performing a pilot study of denosumab treatment in adults with FD at NIH. So this includes a 6-month treatment period with a high-dose ex vivo formulation of denosumab, and then an extensive post-discontinuation phase. One key feature of denosumab is that when its effects are temporary, unlike bisphosphonates, when the drug is stopped, the benefits are lost and bone turnover increases. So we wanted to design this study to really closely evaluate the post-discontinuation period. Primary endpoints have been bone turnover markers, and a secondary endpoint that I wanted to mention is the effect of denosumab on FD lesion activity as measured by sodium fluoride PET CTs. So these are combined functional and anatomic imaging scans where the amount of tracer uptake into the skeleton can be quantified and has shown to be correlated with clinically meaningful outcomes in FD, including fractures, surgeries, and ambulation impairment. So this study has completed enrollment, and we are anticipating sharing the results very soon. But just to share some preliminary data, we have seen very potent effects of denosumab on FD lesion activity. And here you can see sodium fluoride scans in 2 representative patients. This is a woman with severe FD involving her rib cage. She's developed a progressive FD lesion expansion, which has actually led to pulmonary insufficiency, and she was requiring continuous oxygen therapy. After denosumab treatment, she had resolution of her rib pain. She had objective improvement in her lung function and was able to discontinue oxygen. And you can see that's correlated by a decline in FD lesion activity to nearly physiologic levels. This is a patient with very active severe skull FD. This is a different view, a kind of a slice through the CT component of the sodium fluoride scan. And on this view, the more orange uptake correlates with more FD activity. And again, you can see the activity decreased to near physiologic levels, which was accompanied by resolution of her skull pain. So this is very encouraging. However, we do see important effects of bone turnover rebound. So while patients have received denosumab, their serum bone turnover markers have declined, similar to what you see on the scans, into physiologic levels. However, when denosumab is discontinued, we see a massive rebound in bone turnover. And in one patient, this has been associated with hypercalcemia probably because the newly formed bone is undergoing such massive osteolysis that it's releasing excess calcium into the blood. Fortunately, this seems to be manageable with bisphosphonate therapy. However, it's an important limitation from a safety standpoint. Also, not in our study, but in a retrospective series from the group in Leiden who treated patients with clinical FD, they have reported one case of osteonecrosis of the jaw. So denosumab for FD, where are we now? I think we're seeing really exciting potential for effect on FD lesion activity. Right now, this seems to be the only medication that seems to be capable of altering FD activity and changing bone quality. But we have important open questions. It's not clear which patients should be treated and for how long. And we need to better understand the safety of stopping or weaning this drug. So at present, I recommend proceeding with extreme caution, particularly in patients who are young and have very active FD, or in patients who have a significant FD burden. And I suspect we're probably going to know a lot more in the next few years about if and how we can use this safely. And then I just wanted to end with one of our future directions with denosumab. So one potential exciting use of this medication may be to prevent FD lesions from forming in children. So I shared earlier in the discussion after case 1 that FD lesions are established in early childhood and increase rapidly during the growing years. So what this provides is a potential window of opportunity that if we can intervene with a medication to prevent FD lesion formation, we could potentially have a profound disease-altering impact in these kids. And we have data in animal models of FD that treatment with anti-rankle therapies can actually prevent FD lesion development. So right now, one of the work that Vivian is focusing on is preparatory studies for if and how to use denosumab in kids. And she's been performing natural history and biomarker analyses in young children to focus on defining early FD lesion development, which she presented at ASBMR. And we also have a clinical trial for denosumab treatment in children with FD in development. So Viv, you just want to share our update on our case 2?
So the patient was started on calcitriol and oral phosphate with improvement in the labs and in bone pain. The pain is now manageable with NSAIDs and supportive care, and they're holding off on further azoledronate for now.
Why don't you share the takeaway points, Vivian?
Sure. So the takeaway points for case 2. So bone pain in FD is complex. It may be multifactorial and requires a multidisciplinary approach. Hypophosphatemia increases FD complications and should remain on the differential in any patient with pain. And bisphosphonates may be helpful for pain management, but should be used judiciously with the lowest dose and interval needed.
Thanks. And thanks very much. And thanks again to our group at NIH, our fantastic NIH endocrine fellows, and our patients and families. So
thank you so much, both of you, for these very, very nice presentations. I think you touched on, well, everything, this very interesting disease, and I think there is much more to discuss. I would like to start. Allison, you spoke about the secondary hyperparathyroidism in relation to the overproduction of FGF23. And we have a question from Nina Ma. She asks, well, the PTH receptor itself is mediated by GS-alpha. Have you seen any problems related to PTH in FD mass?
Yeah,
Vivian or Allison, yeah.
Yeah. Thank you for that great question, Nina. Very astute. So absolutely, fibrous dysplasia results actually from constitutive activation of the PTH receptor. So in its essence, fibrous dysplasia lesions are like extensive brown tumors. So we do care quite a bit about PTH in FD. And for that reason, we have we don't have really good clinical data to show the effects of PTH on FD lesions. However, I think it's logical to assume that because this receptor is involved in FD pathogenesis, it's not a good idea to let patients with FD run with high PTH levels, because there's at least a theoretical risk that it may exacerbate the FD. So we really monitor the levels closely. We have a really low threshold to try to prevent secondary secondary hyperparathyroidism. We haven't seen PTH dysregulation to be a key feature of FD, at least from what we've seen, however.
Thank you. And then I would like to say I have another question, but I also see a hand raised. Maybe Silvina, you can ask your question in the chat, since we can't use the you can't use your microphone. I'm sorry about that. I had a question myself. You talked about the indication for thyroid ultrasound and testicular ultrasounds. So how worried are you for benign and malignant tumors in both children and adults?
Yeah, no, that's an important question, because GNAS is known in the general population to be a weak oncogene and has been associated with some malignancies. And there's been some very nice work out of Leiden looking at cancer risk in patients with FD-MAS. In general, we don't see a strong oncogenic phenotype in patients with FD-MAS, but we do see some evidence of increased risk. In particular, FD lesions have about a 1% chance of developing osteosarcoma. We see increased risk of breast cancer in women with FD-MAS. The thyroid cancer risk is a little unclear. We very typically see thyroid nodules in MAS patients. In our NIH cohort, about 2/3 of patients will have nodules detected on ultrasound. And of those, only half of patients will have hyperthyroidism. So you have a pretty good representation of people with subclinical ultrasound abnormalities. And the risk of those nodules turning into thyroid cancer, I just don't think we have data to know for sure. We certainly have seen some cases. I'm aware of one case of thyroid cancer, even in a 14-year-old patient with MAS. And I think seeing it at a younger age is a little more convincing for a possible relationship. But at present, we recommend using the same guidelines for monitoring the nodules or biopsying the nodules as you would in the general population. I will say, though, I think it is helpful to do that screening evaluation and for both the thyroid and the testes, because I think it's important for patients to know if they have those type of differences on their imaging. It can be, some of these ultrasound findings are striking. I don't know if you noticed on the early slide, I showed ultrasounds where a patient had unilateral testicular involvement. Any radiologist looking at that, if they didn't know about McCune-Albright syndrome, would call that cancer and take that out. So I think part of the staging evaluation is just empowering the patients to know where they do and don't have disease. Even if we don't think it needs to be monitored closely, I think it's a good idea to know it's there.
Yeah, thank you. I think that's a very important notion to make indeed. Well, I have a question, maybe Vivian, for you. A question about the osteonecrosis of the jaw. This is a question from Jennifer Miller, who also thanked you for this magnificent presentation. Is the ONJ seen using permethrinate and zoledronic acid treatment specifically more in patients who already have craniofacial FD or mandibular FD in comparison to the patients that have other skeletal involvements?
So the question, just to make sure I have that correct. So the question was pertaining to those with the craniofacial FD specifically.
Yeah, whether they have more often the ONJ in the bisphosphonate treatment in comparison to the other patients.
The patients without craniofacial FD.
Without craniofacial, yes.
Right. So I mean, if you have any type of lesion, or if you have craniofacial FD, you would be at higher risk of ONJ if you're getting procedures done in the craniofacial region. So you're just having more exposure to things that could make you at a higher risk of ONJ. But I'm sure Allison could elaborate further on that. But.
No, perfect answer, Vivian. I totally agree. It's really difficult to figure out how much of a role that FD itself is playing in the development of the ONJ, because the craniofacial region is actually the most common place to have FD. So a huge percentage of patients receiving bisphosphonates for FD will have craniofacial FD. I think in our series that we published of 4 patients that 3 of them, I think, had ONJ in an FD lesion and 1 maybe in a non-FD lesion, although I would have to double check and look for sure. So I think what we can say is certainly FD is not protective for the development of ONJ, and it might actually be a higher risk feature, although hard to know for sure.
Yeah, in relation to that, there is one more question from Nina Ma, whether this ONJ is a complication of dental extraction or even seen without dental problems.
No, I appreciate the chance to clarify that, because every time we have seen ONJ in patients with FD, they have had all the same risk factors and profiles that you would expect to increase your risk of ONJ. So all of them got long-term high-dose therapy, lots of bisphosphonates, had invasive dental procedures performed, which seemed to start the ONJ. So I think it's comforting in that I think among the FD population, it allows us as clinicians to identify which patients are going to be at higher risk.
Okay, thank you also from my side from these wonderful presentations. We have another question from Dr. Ken Poole. So he says that on his experience, when people look on biopsies of FT, the fibrous tissue neoplasia completely replaces the normal marrow. And this could be also an idea that the bone lesion is the bystander to the fibrous abnormality. So the question would be if there are any markers of stromal markers that are abnormal in FD.
Yeah, so that seems to, I agree. The one key feature of FD is the way it replaces a normal marrow structure, and it's really an inherent feature. So if you see things like adipocytes or other signs of normal marrow architecture, that makes me less suspicious for FD. And then our current understanding of the pathogenesis is that it's these skeletal progenitor cells that just aren't able to differentiate along the pathway to form those normal marrow structures. That is really the inciting feature in FD, that instead them getting stuck at this kind of abnormal bone forming phase is what creates the lesion. So for that reason, I agree. I think that identifying markers along the pathway of differentiation from skeletal progenitor cell all the way to mature osteoblast is something that could be very useful in characterizing FD. It's not been something that has been worked out very well. From a clinical standpoint, we see really great correlations with osteocalcin and clinical features. It actually seems to be our most consistent bone turnover marker. And some of the work that Vivian shared at ASBMR is she was able to identify that osteocalcin was able to serve as a predictor for children who are going to go on to develop more severe FD progression. So I think both from a clinical standpoint and from a translational standpoint, identifying those markers would be really helpful, because potentially if we see improvement in FD, for example, treatment with denosumab, if we see those markers progressing into a more normal state of differentiation, that could potentially be encouraging.
Okay, thank you. Another question is a clinical question from Dr. Almohaya. So he asks about correcting phosphate levels before bisphosphonates if you think it is necessary, and then dose and interval of denosumab, and of course the analogy to postmenopausal osteoporosis, switching to bisphosphonates to consolidate then the effect. You are going maybe to look into this because you said you have this treatment protocol where you will be, but maybe you can elaborate, yes.
Yeah. So I think the case Vivian shared showed that we certainly do recommend correcting hypophosphatemia before giving any anti-resorptives, really for 2 reasons. One is because although the pain is probably multifactorial, the phosphorus is not helping. So if you can correct the phosphorus, you will likely improve the pain, and you may not even need to use bisphosphonates. So I think in the case that Vivian shared, case 2, that was the case. Also, just in general, if when bones are in a state of osteomalacia, it's best not to give an anti-resorptive, because you can potentially impair the ability of the body to remineralize that lesion. So you need osteoclasts to kind of turn that lesion over and incorporate new mineral if you can correct the mineralization defect. So for denosumab, yes, stopping this medication is just going to be really tricky, both because you'll lose the therapeutic effects, and second, because of this bone turnover rebound. And the degree of the bone turnover rebound is going to be very different depending on the degree of FD. So the group at Leiden reported a retrospective review where they stopped denosumab, I think in about 10 or so patients, and saw no hypercalcemia, which is reassuring. But I think on the whole, their cohort is less severely affected than, for example, our NIH cohort. So that's not safety data that I think we can readily apply to someone with more severe FD. In our patients with panostotic FD, we've seen massive rebound and severe hypercalcemia. So I absolutely agree that treatment with bisphosphonates following denosumab is something that is likely to be helpful. And I've been following that literature in postmenopausal osteoporosis probably closer than any other pediatrician, because I would like to see how we can translate those findings. On our protocol, we have been giving bisphosphonates at the time denosumab is stopped, and we're still seeing rebound, but we've had good results with targeting repeat bisphosphonates infusions based on bone turnover markers. So fortunately, the bone turnover markers in the blood are a really good predictor of who's going to run into trouble. So if you see them coming up quickly, kind of dosing as needed. So I do think it is certainly possible to manage this rebound safely. You just have to be at a center where someone really understands bone metabolism and have a patient who's willing to be very compliant and come back for labs whenever you need it.
Yeah, this is also very concordant to the advice of the CTS position paper of denosumab discontinuation, pertaining also bone turnover markers and then when to start bisphosphonates. Maybe another aspect which has been raised by Dr. Matzika, it's about OA, degenerative OA. So she makes the point that it is a common feature or a prominent feature of XLH, but also FD patients have been reported to have higher rates of OA. And she would like to ask about Burosumab. Also, I guess, coming from the background of XLH and improvement of OA in these patients, and do you think that it would be also something that could translate into FD?
Yeah, and can I clarify, by OA you mean osteoarthritis?
Yes, degenerative osteoarthritis. Yeah, no,
that's a big problem in our FD patients too. I suspect for the similar reasons as you see in XLH. It's the skeletal deformities lead to altered weight bearing, and then putting extra stress on the joints. So we talk about this a lot. It's one reason that we are very aggressive about looking at alignment in FD, because leg length discrepancy. So in XLH, it's bowing, which tends to be the biggest problem. In FD, you have not only bowing, but you have overgrowth because the FD lesions tend to be longer. And you also have fractures, which can, and then you also have mosaicism. So if you have extensive FD in both legs, the chances of those two legs being the exact same length are very, very low. So we use a lot of shoe lifts. We really aggressively follow our patients with physiatrists to look at function, range of motion. And then we really try to use any type of minimally invasive orthotics and reassess them frequently to try to improve that alignment, both to prevent OA and also because I think it's a key part of preventing skeletal deformities. FD is so soft that it doesn't tolerate that altered weight bearing very well. And we found that leg length discrepancy is one of a big feature that contributes to progressive scoliosis. Because you imagine that if you tip your hips, then because of leg length discrepancy, your body will then sort of move your shoulders in the opposite way to try to keep your head straight. And all of that abnormal weight bearing will extend to the spine, the hips, the knees, the ankles, all the way down. So it is a problem. It's also something I think is important to consider when we prescribe mobility aids. One consideration, if you're trying to decide if a patient should be someone who uses crutches versus someone who uses a wheelchair, is whether or not you're going to increase risk of arthritis in the upper extremities. Because once that develops, managing the pain is really difficult. And XLH hypophosphatemia seems to be the main driver of the deformities. I think that's not known for 100% sure. There may be some underlying skeletal dysplasia related to effects, but the hypophosphatemia leading to the bowing is a big factor. In FD, I don't think the hypophosphatemia is quite as strong a driver, although it can contribute. So I think the bigger component for preventing OA is focused on alignment, but certainly managing hypophosphatemia, I think, can help. And it is one of the reasons we're interested in Burosumab.
Okay, thank you. Maybe last question, Vivian, if you'd like to take it about pain and analgesia. If you would then recommend topical analgesics, topical anesthesics, or heat cold, or if you have any experience with alternative therapies such as acupuncture in this in the treatment of patients where you're involved.
I mean, I think that pain is a very complicated symptom and it's very difficult to treat. But it requires kind of a multifaceted, holistic approach. So we do have several medications that we can use, and there are alternative treatments that you can use as well that can help. And so everything from heat and cold, and some people do use acupuncture. Those can help as well with pain, or NSAIDs. And then, as Dr. Boyce had mentioned before, even, you know, bisphosphonates for bone pain specifically. So there are different avenues to take for bone pain, and there's not one specific treatment that would be the best treatment. And so it's a combination of all of those factors. And Dr. Boyce gave a really good talk actually on pain not too long ago. If she has anything further to elaborate about that.
No, I agree with you completely.
Thank you. Just last comment from Dr. Pachika. She's a pediatric orthopedic surgeon, and she says that prophylactic nailing for long bones, also used similar to OE patients, would be a surgeon's insight. For this
Yes, and I so appreciate it. Thank you for sharing it, because surgeons are arguably as important as endocrinologists in this disorder. And establishing the indications for prophylactic rotting is so important in FD. FD, I would state, and I know I'm biased, but I think it's even harder than OI, because you have to worry about that proximal femur with the femoral neck shaft angle in FD. So you have even more like bowing than in OI, where you tend to have more brittle type of fractures. So I would definitely encourage ASBMR to engage the surgeons on management of FD, craniofacial and long bones, because it's challenging.
Okay, I think we are approaching the mark of the hour. It has been really wonderful, your talks and also the interaction. We have a lot more questions. Maybe we can save that if you will be available for people to reach out to you and also ask on an individual basis. But I will now turn back to Subcommittee for closing the session.
Right, thank you. I'm sure I speak on behalf of everyone when I thank Dr. Boyce and Dr. Szymczuk for this wonderful presentation and really excellent discussion on fibrous dysplasia. I would like to close the session and remind you all that this is our last session for the year, but we will be back next year with our first session on hypothalamic amenorrhea and bone health, which will be held on Wednesday, January 12th at 1 p.m. Eastern Standard Time. And this will be presented by Dr. Amarim and Dr. Fazeli. Could I also ask any of the attendees if you have any topics that you would like to see presented, or if you would like to present yourself, please feel free to send us an email and with any suggestions. And with that, I'd like to close the session and thank you all.
Thank you.
Thank you.